Oh my God, where am I at? I'm sorry, guys. Okay, so let me go. Okay. So life-threatening emergency. So if we talk about anaphylactic shock, how fast does that happen? Pretty fast, right? No one's like, oh, I got stung by a bee and 4 days later I couldn't breathe, right? It's instantaneous, right? And then I think about, so anaphylactic shock, if I think about cardiogenic shock, how fast does that happen? Pretty fast. The number one cause of cardiogenic shock is a massive MI. No one's like, listen, I've been having this MI for a week. Now I'm in shock, right? And hypovolemic shock. That can happen over a couple of days if you have somebody that slowly dehydrates. But if you have somebody in a massive trauma that's bleeding out, it's also going to be very quick. Rarely, I should say almost never, have I ever seen somebody that like got a nail stuck in their foot and they're like, whoo, 2 hours later, I was in shock, septic shock, right? So sepsis is a slower process. So you'll see the patients go through this response system a little bit slower. So I want you to think about the life-threatening emergency and the type of shock that we're talking about, because obviously hypovolemic shock is somebody who's in a massive car accident with a liver laceration. We got to take care of them way quicker than somebody that now has an infection that might go into shock in 3 or 4 days. Okay. So hypovolemic. So this patient's either dehydrated or dry. And remember, hypovolemic shock is in the vascular space. See, this is the patient like your liver failure patient that has a fluid volume deficit in the vascular space, but they may have a fluid volume excess because they have ascites, right? So they might have a weight gain, but they're actually dry in the vascular space with the hypovolemic shock. They could be bleeding out, right? We just talked about that. Maybe somebody has massive trauma, they could be bleeding out. Okay. Or they're extremely dehydrated. So the cells are dry and the vascular space is dry. So hypovolemic shock, we're lacking volume in the vascular space. Cardiogenic shock. So let's look at it this way. Next to hypovolemic shock, write down pool. The pool is empty. So when we think back to hemodynamics and how I reviewed hemodynamics, it's very intentional because I knew I was going to talk about shock this way. So hypovolemic shock, the pool is empty, right? You got to fill it back up. Cardiogenic shock, what's our problem? The pump's broke, right? Got to fix the pump. You got to focus on fixing that cardiac tissue. And then distributive shock is pipes. So those of you that you've had on, that have been with me on clinical, what happens in septic shock? The blood vessels, you're right, they go wide open. It's a pipe problem. Everybody vasodilates. So in septic shock, it's considered, and I think of those blood vessels, they distribute wide open, okay? So distributive, wide open. Anaphylactic shock, everyone thinks the vessels get real tight and clamped down because we worry about the airway. That happens to the airway, but the blood vessels go wide open. So anaphylactic shock, same thing. Vasodilate, it's a pipe problem. And I'm not gonna ask you any questions about neurogenic shock because you already studied it. I gave you a question on neurogenic shock, right? On this last test. But it's the same thing. When we had our patients in neurogenic shock, what did we give them? We gave them neosynephrine. We gave them vasopressors because it's a form of distributive shock. Blood vessels vasodilate. We lose our autonomic nervous system response to clamp down. Okay. So these are the 4 phases. Okay. So your initial phase is the injury, right? What caused this shock? So we already know it's a perfusion problem. So of course, cardiac output's going to be low. Guess what else? Cardiac index is going to be low. Stroke volume is going to be low. Blood pressure is going to be low. MAP's going to be low. Remember I said before they all go together? They're all going down together here too. And guess what? Look at our first responders. Beta. Guess what they do? They come in to help a little bit. They're like, oh, we got a little bit of a bad cardiac output. Okay, beta 1's going to kick in. Heart rate goes up. Beta 2 is going to kick in. Respiratory rate goes up. Okay. So compensatory, now alpha's like, what the hell's going on, right? Alpha's like, are you kidding me? We've got this low intravascular volume. what is going on? I got to try to save myself. So cardiac output drops, blood pressure drops. We have a tissue perfusion problem, hypoxia to even our non-vital organs, and our kidneys and our hormonal adaptive mechanisms are activated. Right? So now alpha. We're trying to compensate. So our body tries to clamp down. It's trying to compensate here. Why do we become acidotic? Because of the hypoxemia. Absolutely. We're hypoxic and acidosis. So what happens if I run out of oxygen for energy? Anaerobic metabolism, right? So now I'm kicking over to muscle energy. So what happens when that happens? Your muscle breaks down. What are we going to see? Lactic acid. Absolutely. So we go into lactic acidosis. And when we're in acidosis, what happens to our K? Right? Acidosis K goes up. This is nothing new. You guys have learned this all semester. We talked about it all semester, right? So what do we have to do? Well, if I'm bleeding out, right? Let's stop the bleed, right? So I know students are like, this is like my liver example, right? When I came in here, it was like, give her lactulose. And I'm like, my blood pressure is 80/40. And they're like, give her lactulose. You guys are like, give her lactulose. Okay. So the students do the same thing. And I'm like, okay, I'm in hypovolemic shock. Save my life. Somebody save my life. And everyone's like, we're going to give her a and I'm like, good. And this person's like, I'm going to give you Paxil. I'm like, good. And you're like, I'm going to give you norepinephrine. And I'm like, great. Guess what? Still bleeding out the liver from the liver. You got to stop the bleed. What if I'm vomiting and shitting everywhere? You got to stop it, right? So we have to stop, you have to get the antiemetics, antidiarrheals, replace the fluid, replace the volume in the vascular space, right? So I know that sounds silly a little bit, but students, I promise you, always forget to pick that answer. They're always like, I'm going to get vasopressors. And I'm like, good, I like that. You plug the hole. I'm going to plug the hole. No, okay. We got to stop the bleed. So some of the interventions might be prep the patient for surgery, right? We don't know how they're bleeding, how fast they're bleeding. Do you guys remember the story I told you about my patient that came in septic at St. Joe's? Right? We're like, we don't know why he's septic, but he's septic. Blood pressure's down. Vessels are wide open. We're throwing fluid in. And I'm like, whoop, there goes the boot. I'm like, source found, right? But if you can find the source, and what are the chances? Do we know what kind of microbials can be growing in that foot? We have a better chance. I can tell you probably what more likely is going to grow in the lungs versus what's going to grow on the foot. So as soon as we find that source, we culture it, and then we start those broad spectrums, right? So for septic shock, we've got to find the source of infection. Cardiogenic shock. Why is your patient in cardiogenic shock? Do they have an MI? Do they have cardiomyopathy? And the heart, just weaken? They throw like a PE or something, that we have this tissue hypoxia. Okay. So now we get to progressive. Our body can no longer compensate for itself. So we progress to a phase that's almost irreversible. Compensatory mechanisms begin to feel. So beta 1's like, I'm trying. Ding, 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 ding. My heart rate is 150. Okay. Respiratory rate, what? 35. And my vessels are clamped as tight as they can. But if I said to you, hey, to survive nursing, and you want to pass this course, you've got to maintain a heart rate of 150 and a respiratory rate of 35 for the next 24 hours. Guess how many people would pass this course? Because you guys would literally have to run around this building for 24 hours, right? To keep your heart rate and your respiratory rate up that high. Can anybody do that? I'll never be able to do that. So hopefully that's never enough. You ever see people that are like, I'm gonna run for 24 hours. I'm like, oh, I can come give you some bottled water. So think, that's how I want you to think about those first responders. They can only help for so long. So the heart rate goes up, respiratory rate goes up, vasoconstriction happens, alpha agonist happens, but now it's exhausted. Okay, so our compensatory mechanisms start to fail. We've got our lactic acidosis, right? We flip over to anaerobic metabolism, and now we vasodilate. But blood vessels give way. We're too tired. I can't constrict anymore. I'm too tired. I'm exhausted. Okay? What happens when the blood vessels give way? You have vascular permeability, so things just start leaking. All the fluid in the vascular space starts to leak out. This starts an inflammatory cascade. Now we're like, oh my God. The body's like, what do I do? Let me send some cells there to try to fix the problem. So it starts to cause this inflammatory cascade and now a clotting cascade. Now we don't know what to do. We're like, I can't clamp down anymore. So let me start sending some cells there and let's start clotting. Okay. Okay. So you'll see the systemic inflammatory response. That's what SIRS means. And if we don't fix them here, they are going to die because then we get to irreversible. It's refractory. It's refractory. Now we start shutting down organs. We go into multi-organ. Who was on clinical with me on Tuesday? Abby? Do you guys remember Abby? Was anybody sitting with Abby? And she's like, they're going into mods. They're going into mods. Oh, who was your patient? Were you sitting by her when she was talking about that? So Caitlin had a liver failure patient. What was she found down like 2 days? Yeah. Unresponsive. We didn't have her on any sedation. So we're like, is she unresponsive because of lactose or because her ammonia is so high? And she was yellow. She was really yellow. And or we're like, she was found down. They said maybe for 2 days. Is this a hypoxic injury? So now do we have a hypoxic? Was this a perfusion problem? Like they were still trying to figure it out. But because she was so sick, we started to see multi-organs fail. So the kidneys were failing, the liver was failing, the heart was starting to fail. So now we get into mods. Well, if your heart's failing, do you need the kidneys and liver and lungs to help? Yeah, but they can't because they're sick. So that's why it becomes refractory because nobody can help each other. And we start to see multi-system organ failure. Okay, so let's talk about shock state. MAP less than 60. You guys know that. The textbook says 65. We want our MAP less than 65. We're talking about shock less than 60. Global hypoperfusion. How do you know that you're not perfusing organs? How do you know? Okay, so capillary refill, that tells you periphery. What about an organ? So lab values. So we might see lactic acidosis. We might see a high K. How else? Okay, who said urine output? Good, urine output. So I'm not perfusing my BUN and creatinine are going to go up, right? How do I know if I'm not perfusing my brain? Would you say? Okay, so we might have some cerebral edema. We might not be perfusing our brain. Our patients are going to be confused, right? First thing, level of consciousness change, right? How do I know if I'm not perfusing my heart well? What would your vitals show? Low MAP, low blood pressure. What else? How else do we know I'm not perfusing that heart? Maybe some chest pain. How else? Cardiac output, that goes along with vitals. One big thing you guys are missing. Pardon? So hemoglobin's oxygen carrying capacity. Heart rate, I like it. Now we're starting to have this rhythm. So now I have PVCs. I may become bradycardic. If you remember, high K, K stops the heart. You got a low K, you're going to see those beats come fast, right? PVCs, PACs, they go into AFib. If you have a high K, the heart rate becomes slow. So we start to see cardiac dysrhythmias, right? We're not perfusing our heart. So now they might go into AFib. We might have runs of VTAC. So you know all that information. If I said we have global hypoperfusion, and I give you an example, well, what organ system am I talking about? If I say liver, you guys are gonna be like, oh, ALT, AST go up, right? Maybe my billy goes up, my ammonia goes up, my albumin goes down, right? You guys already know that. The patient might be jaundiced. What happens if it's respiratory? One patient's tachypneic, it might be hypoxic, okay? So that's global hyperperfusion. Look at the organ system that we're talking about. I'm sorry?
Did you say you'd be tachypneic if you're not perfusing your lungs?
Yeah. Yeah.
But you're braiding.
It depends. So if you're hypokalemic, you're going to be tachycardic, right? Because if low K makes the heart go faster. I always think about this. This is how I remember this moment. when they would do like euthanasia for prisoners, they would give a potassium bolus, which would stop the heart. So high K actually can slow down the heart rate, make them a little bit bradycardic, it's called tensive waves. Low K, that they're more likely to have PVCs, PACs, a little bit tachycardic, go into AFib. This is why if you're working on a cardiac unit, almost always the cardiologists want the K higher than 4, the MAG higher than 2. Almost always, even though 3.8 is still within our normal parameters, that's not okay for cardiology. But you'll know that if you worked on a cardiac unit. Otherwise, if you saw a potassium of 3.8, you wouldn't call the doctor and be like, it's 3.8. They'd be like, okay. But that's how important potassium and magnesium is to cardiac function. Okay, did I answer your question? Okay. And then lactatemia. I never say that well. Okay, so we're gonna see a lot. We're gonna see high lactate. Okay, what's your normal lactate level? So it's like 0.5 to 1, up to 2 even, but they say greater than 4, you think shock, greater than 4. Okay. Might have a little lactic acidosis, but greater than 4, I'm thinking shock. Okay. We also look at the lactate to trend if our interventions are working. So every exam, I write a question like this. So here's a clue. I'm going to write a question about this. How do I know my treatment works? What was the problem initially? If I have a lack in tissue perfusion, how do I know I'm perfusing my tissues? Okay, so tissue perfusion is a major. So I write it almost the same way every time I write it. How do I know that this treatment was effective? Whatever treatment I'm talking about, right? How do I know it was effective? We'll always go back to see what your problem was initially. So we've got to start perfusing. We have to make sure we have oxygen. Okay. This goes back to that oxyhemoglobin dissociation curve that we talked about when we talked about respiratory in the beginning of the semester. And I said, I could give them 100% oxygen all day long, but if my hemoglobin's 5, it can't carry it, right? I can have a hemoglobin of 13, but if my patient is not pulling in their air and we're not ventilating well and they're not getting oxygen, that hemoglobin can circle all day long, but it's not going to be able to deliver oxygen because it can't pick it up. Okay. So we've got to maybe give blood. We maybe have to give fluid. So we can give crystalloids, colloids. We might have to give vasoconstrictors. We may have to give vasodilators. You guys are probably all like, oh my God, seriously? You just told us everything's wide open. But write down vasodilators, write down to next to that cardiogenic shock. Cardiogenic shock. Yeah. Dilators. Because in septic shock, anaphylactic shock, and neurogenic shock, we're already wide open. So if you give them a vasodilator, you're going to kill them, right? Hypovolemic shock, I got to fill it back up. So if I make it wide open, how much more do I have to fill it? Not good. But if you have a pump, let me give you guys a break. I'm going to grab a writing pencil. If I have a pump like this is your heart, okay? Here's your aorta. This is your afterload, right? So if I give a vasoconstrictor, okay, and somebody in cardiogenic shock, vasoconstrictor, and I have a pump that's broken, how hard does this pump have to work to pump against that high afterload? Really hard. Well, that doesn't help this. This pump's broke. So what do I have to do? Fix the pump. And then if needed, I could vasodilate to decrease afterload and decrease the workload in the pump. Does that make sense? So I've never given a vasodilator to anything but cardiogenic shock or somebody that was in a hypertensive emergency. Okay. Otherwise, we should be thinking vasoconstrictors. And I have had to give vasoconstrictors in cardiogenic shock, but it's not common. Inotropes, right? So inotropes is almost first line for cardiogenic shock, right? Because the pump's broke. What's the problem? We'll pump pipes. Pump's broken. We got to give the inotrope. If I have somebody that is in hypovolemic shock, right? They're bleeding out. And I fill them back up. So I'm like, bing, stop the bleed, blood pressure, fill them back up and add a vasopressor. And I still can get that cardiac I'll put up, and sometimes we do add a It's just not first line. Cardiogenic shock is first line. Okay. Okay, so fluid, we already talked about that. Crystalloids, colloids. You guys already know your fluid and electrolytes, right? We can give sodium bicarb. St. Joe's loves sodium bicarb. How many of you guys give sodium bicarb at St. Joe's? Mike was pushing it like every hour. He had a sodium bicarb drip running at 2. Is it sodium bicarb? Jessica, you had sodium bicarb running. Sodium bicarb running at 250 an hour. And then every hour he was getting an amp of bicarb, like we would give it in a code. I'm like, well, you could be team lead on a code now because you know how to open all the ampules and like screw, push. I was like, really? This has been given it every hour. They love it at St. Joe's. But the research hasn't really shown that it's been super effective in shock. We don't use it as much. Okay. But it may be indicated. Blood, you know, the guidelines now say we don't give blood unless the hemoglobin is less than 7 or the patient is extremely symptomatic. So who gave blood at St. Joe's when the hemoglobin was like 10 or 11? Yeah. So I was like, wait. Well, then I find out that the guy was like literally pouring buckets of like frank red blood. It was his rectum he was bleeding. Yeah. And they were getting him for like an emergency scope. So I was like, oh, okay. But I was like, wait, his hemoglobin's 11. Are you sure you guys are giving it on a right? She's like, oh, yeah, calm down. I'm like, I know, but it's like 11, you know? We don't usually give it less than 7, but it was coming out as fast as it was going in. They couldn't get him to the EGD lab fast enough, right? So, so we use blood. You either anticipate a huge blood loss. Sometimes we give blood during surgery. So if we schedule the patient for surgery, give blood during surgery so that we can prevent that oxyhemoglobin dissociation curve after surgery. If we know that they're going for major like hip replacement, they might need blood after. Vasoconstrictors increase after load. Okay, so remember your vasoconstrictors are going to clamp down, increase afterload, which in turn does what? What's our goal? Increase perfusion and cardiac output. Absolutely. And then they say now, we used to, gosh, I was just talking to somebody the other day. I was like, God, it's really hard to believe I've been a nurse almost 20 years now. But when I first started and then I was in the ICU, it would be like 4 or 5 days before we would start enteral nutrition. Everybody was on TPN. So we were giving IV nutrition. And the research showed that patients have a better prognosis if we feed the gut within 24 hours, 24 to 48 hours of the traumatic event. I don't mean ejected from the car. I mean cardiogenic shock. You know, whatever this traumatic thing that caused the illness in this patient, the sooner we start enteral nutrition, the better the patient does. And we found that giving that nutrition IV was actually increasing the rate of sepsis because of all the sugar and all the chemical components of that IV nutrition. So now we want to focus. So as a recommendation, hey, listen, this patient's been here 2 days. You guys want to start tube feeding? What are we doing? Have we done an X-ray? Do they have an obstruction? Why wouldn't we be giving them nutrition? And then glucose control, right? Any kind of stress, the glucose goes up. So we need to control it because it actually increases the metabolic demands and it increases the risk of infection, right? I feel like almost everybody in the ICU gets blood sugar checks. Okay, so how do we support oxygen? Well, if they need an airway, we put one in. We make sure we put them on a ventilator if we need to. We can give O2. We don't have to put them on a ventilator, but if we've done our non-invasive interventions and they're still not any better, then we have to ventilate them. We do frequent labs on these patients. Okay. Make sure we think about lactic acidosis. Amber, on her patient on Tuesday, they were rounding. I'm like, oh my God, I love this. And I sat there the whole time with my mask on smiling. And I looked there, I was like, I love this so much. But the pharmacist was there, the doctor, the charge nurse, the nurse, and there's somebody else there. Anyways, they said, okay, this is what's going on with this guy. And they said, okay, do we have DVT prophylaxis? And the nurse was like, hey, I'm really worried about this. This culture came back this. And they're talking about the cultures. They're talking about the antimicrobials. They're talking about DVT prophylaxis. The nurse is like, hey, listen, he's not on stress ulcer prophylaxis. We need to think about that. Or somebody said it, the pharmacist maybe. But they had this wonderful dialogue. And guess what? The patient was on stress ulcer prophylaxis. They weren't. So somebody picked that up in rounds. And they said, okay, what about this? And what about this? And what about this? So just being able to look for those things. If you have somebody in shock, are we doing lactic acid? Are we trying to prevent complications? Okay, so that's where that institute evidence-based practice protocols go. DVT prophylaxis, stress ulcer prophylaxis, ventilator associated pneumonia prophylaxis, right? Okay, this is a book concept map. So if you like concept maps, if you like something visual, it's definitely a lot prettier than mine. But if you like it, it's on there. It's the same thing as we've been talking about, but if you like to study by a page concept map. Okay, so let's go into the specific types of shock. So hypovolemic shock is absolute hypovolemia. So this would be loss of fluid from the vascular space. You could have relative hypovolemia, and this is when the fluid leaves the vascular space because when we lose our circulating volume. It doesn't leave the body, it just loses the vascular space. Okay. I'm not going to read you the patho. We're going to talk about it. Right? There's nothing in the vascular space. You lost it either because we're bleeding or it's leaked out. So what do you see? So let me tell you this too. You guys go back and look at your hemodynamic parameters. You need to know them for the test. I promise you. You got to know. So, but you know them already. You look them over real quick. You already memorized them. They'll come flooding right back to you if you can't think of them right back. So this isn't new, right? Decreased cardiac output, decreased cardiac index, decreased stroke volume. What did I tell you? They all go down together, right? They're going to do the same in hypovolemic shock. Preload and afterload, right? So in hypovolemic shock, we have a decreased preload. Why? What is because we don't have volume. Preload measures volume. So your wedge is going to go down. Your RAP and your CVP are going to go down. And then there's that beautiful alpha agonist. There's your first responder. Boom, clamps down. So in hypovolemic shock, you're going to see low cardiac output, low cardiac index, low stroke volume, low blood pressure, low MAP. But you're going to see a high heart rate. You're going to see a high respiratory rate. You're going to see a high afterload. And because we're down volume, you're going to see a low CVP. Does that seem confusing to anybody? You already studied it. So shock, everyone's like, oh my God, shock. Okay. So we know our pH is going to be low because we're acidotic. Our PaCO2 goes up because we're acidotic. We're going to have a high K because we're acidotic, and our lactic acid is going to be up. All right. These are your nursing diagnoses. Okay, medical management. So correct your hypovolemia. What's the cause, right? Plug the hole, stop the vomiting, stop the diarrhea, right? Stop the fluid from shifting out of the vascular space in hepatic failure patients, right? Stop the source of the loss, restore tissue perfusion. So what's my problem? Pool pump pipes. The pool. So what do you got to give first? Fluids, right? I lost volume, so I got to give the volume back first. Let me make it this way. What would happen if I gave my patient a vasopressor first? I can clamp them down all day long, but is it going to make the perfusion much better? Maybe a little better. Is it going to make it a lot better? No, because I can clamp shit all day long, but if I don't have the volume to transport it, it doesn't matter. So volume first. If we fix it by replacing volume, great. If we don't, then we add our vasopressor. What's our number one vasopressor? Levofed, norepinephrine. Think about it every single time in shock. Levofed or leave them dead. Levofed or leave them dead. So here's my exam question. Right. The client comes in, motor vehicle crash, ejected from the vehicle. Right? Liver laceration. Hemoglobin's 5, cardiac output's 1, MAP is 50, heart rate's 120, respiratory rate's 34. The patient's intubated at the scene. The nurse gives 2 units of packed cells, 2 liters of fluid. How do we know the therapy was effective? How do you know? What goes up? Okay, your CVP goes up. Hemoglobin goes up. What's the problem? Tissue perfusion. How do I know I'm perfusing my tissue? My MAP goes up. My cardiac output goes up. I'm peeing. I'm making urine. I'm not batshit crazy because I'm perfusing my brain. So how do you know the drug was effective? Well, my blood pressure goes up. My MAP goes up. My capillary refill's better. I'm making urine, right? It will. Yeah. So we don't naturally, because it's a first responder, the first responders correct themselves when we fix the problem. Yeah. It's almost why we never ever treat afterload. It's rare that we treat afterload because afterload is responding to a problem. It's a first, that's why I teach it as a first responder. Like no one's like, whoa, did you see their afterload? Big problem. No one walks around with bad afterload. We treat the afterload if we absolutely have to, but if we treat the condition, the afterload corrects itself. If we treat the condition, the heart rate corrects itself. If we treat the condition, the respiratory rate corrects itself, right? They're only abnormal because we're responding. Okay, so there's your concept map. There's another one. Okay, questions on hypovolemic shock. You okay? You need a break? Okay, let's go cardiogenic. This is my least favorite type of shock. Shocker, right? All right, so this is a pump problem, right? Got a pump problem. My pump is broke. Okay. Usually the muscular mechanical function of the heart, most common acute MI. Okay. ST or non-ST elevated MI, he turns them into cardiogenic shock. The left ventricle, if it's not working and we're not perfusing it, we're incompatible with life. We've got to get that left ventricle going again, right? All right. So this is your patho. You guys know how I am about patho, but I don't want to just read this off the slide to you. So if we don't perfuse the pump doesn't squeeze. Then we don't have a cardiac output. And then we don't have perfusion to the tissue, right? Okay, so my cardio, I want to point this out to you. Oh, there we go. Okay. So the performance slows down compensatory vasoconstriction. Or I'm sorry, slows down. And then we have this compensatory vasoconstriction. It increases myocardial afterload and low blood pressure worsens because of myocardial ischemia. So that was just what I was talking about with the pump and the afterload, right? So typically my alpha, my first responder is like, oh, we've got a low cardiac output, right? This pump's like this. And the alpha up here is like, oh, you need me? Okay, I'm here. Boom, clamps down. The pump's like, oh my God. Now instead of just walking down the street, I feel like I'm running up a hill, right? So now we're like, oh, even though the body's trying to save ourselves, it still doesn't help this pump, right? It doesn't help. So that's all that means right there. That's what that sentence means. Oh, here we go. Okay. If all the pulmonary edema means is if the heart fails, right? If our heart fails, what happens to the fluid? It backs up, right? So if your left ventricle fails, it backs up to the left atria, it backs up to the pulmonary vein, and it backs up around pulmonary circulation. So these patients end up looking like they're in heart failure. They're in fluid overload, okay? So look at this, decreased cardiac output, decreased cardiac index, systolic blood pressure drops, and our urine output drops. You get it? So in cardiogenic shock, if we're in heart failure, what happens to our BNP? It's gonna go up, right? BNP goes up in heart failure. These patients might have chest pain. Somebody mentioned that earlier. They're gonna be tachycardic because that's compensatory. There's beta 1, right? Beta 1's like, whoa, I'm here. Respiratory rate, right? So initially these patients might be alkalotic and go like this, but then they will end up acidotic. We end up with pulmonary edema. So look at these numbers. Cardiac output. What is cardiac output in cardiogenic shock? Everybody say high or low? Low. Cardiac index. Stroke volume. That. Blood pressure. Good. What happens to afterload? High or low? High, because it's compensating. What happens to CVP and wedge? High. Because what happens is that ventricle fails. So I've got my afterload, my preload, my ventricle, right? Ventricle fails, so my cardiac output and all that stuff is down, right? My afterload's like, let me save you. Let me save you. Clamps down. So I got a high afterload. But this pump fails. Guess what happens to all that fluid? Backs up around the lungs, backs up into the pulmonary artery, which is where we measure our wedge pressure, backs up into the right ventricle, the right atria, and the preload. So our preload goes up. So these patients are going to have clinical manifestations of heart failure, jugular vein distension, hepatic engorgement, right?
It's essentially because they're in fluid overload.
Well, it's because we can't afford to advance the fluid. That pump broke. This is like the septic system in the basement, right? So if your septic system in the basement fails, it doesn't mean that somebody's dumping buckets of water in my basement. Nobody, hopefully not. Nobody go do that to my house. Whether you love me or don't love me, do not take a hose and dump water in my basement. It doesn't mean that somebody's dumping water in the basement. It doesn't mean that somebody's dumping water on this patient. The pump fails. So if you have a septic system in your house or a sump pump and it fails, the water just backs up, right? It's the same thing in our cardiac system, right? It's the same thing. The pump fails, so the fluid's just going to back up. They do end up eventually in fluid overload. It's not like they necessarily started in fluid overload. I mean, I could have a massive MI right now. That doesn't mean I'm in heart failure, but I will go into heart failure. Does that make sense? Does that kind of answer your question a little bit? Okay. And of course, they're hypoxic. Well, yeah. I mean, the fluid's backing up around the lungs. So we've got bad gas exchange, right? Okay. All right, there's your collaborative problems, your nursing diagnosis. So treat the underlying cause, right? We're always going to go back to that. Hypovolemic shock, plug the hole, stop the vomiting. What is our cause of this heart failure? If it's an MI, we got to fix the MI, right? So, first line, what did I say? Inotropes. What's my problem? The pump. So I can give vasodilators, I can give diuretics, but those are temporary measures to help the patient for a short period of time. But if I don't fix that pump, they don't matter eventually. Yes?
Are the only inotropes the 3D ones, the dopamine, DIG, and
Dopamine? Yeah.
That's all?
Yeah.
And that's positive.
Positive inotropes, yeah. You don't want to give a negative inotrope, like something that would have like a, I don't want to say a beta blocker effect, but because then that would decrease contractility. In these patients, we need to increase contractility. Okay. Let's see. So initially, so this is where students sometimes don't like cardiogenic shock. Students are like, just it goes opposite of everything else. So if this patient comes in, let's play case study. Your patient comes in, they're hypotensive, short of breath. They may be having some chest pain. We don't know if that's because they're hypoxic because of tissue perfusion or because they're having an MI, right? So blood pressure, cardiac output, cardiac index, MAP, all that's down. They're tachycardic, their respiratory rate's low. Do you think if my patient's MAP is 50, I'm going to wait until I get the BNP back to see if they're in heart failure? No. So initially, when these patients come in, guess what we do? Hit them with fluids. You guys are like, what? This is a heart failure patient. I'm like, I know, but we don't know that yet. So we give fluids and we give vasopressors to increase. But as soon as we recognize that it's cardiogenic shock, and we say, whoa, 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 where's my inotrope? So I got to get the pump working. Okay. Once the pump is working, I can take off some of that fluid and I can vasodilate if I need to. So that's why you'll see this vasopressor here, and you're like, wait a second, you just told me we're going to give a vasodilator. Well, yes, that's true. But if the patient's blood pressure is down, I can't give a vasodilator, right? Until I get that pump working and bring that cardiac output up. Once I get the pump working, bring the cardiac output up, then I can vasodilate. You see how it says after the blood pressure is stabilized? So then students are like, well, how are we going to ask the question on the test? Are you going to be confusing? And this is not for you. I'm just saying it. I know I did. So if I write a question and it says cardiogenic shock, then you're not going to go in and give fluid and vasoconstrictors. You're going to kill them, right? You took the pump from almost not working at all to completely broken. But if I said to you, the client presents to the emergency room Cardiac output is 1, the same parameters that you used minutes ago. MAP is 50, blood pressure, systolic blood pressure is 80, heart rate's 150, respiratory rate's 35. And I give you those numbers. The nurse provides which interventions. You have no idea what type of shock. I've given you no other information. So if your cardiac output's low, can you give fluid? Yes or no? Yeah. If your cardiac output's low, can you give blood? Yes. Can you give a vasopressor? Yes. Right? That's not tricky. So don't go on a bandwagon. It's like, oh, it's cardiogenic shock. If I don't say in the question it's cardiogenic shock, then it's not. It's just shock. And if you talk to any emergency room nurse, they will tell you the same thing. You start bolusing the crap. You guys know, right? They come in, no one's like, well, let's wait. Let's just wait an hour until we get our blood work back. We'll leave our map at 50, and then we'll decide if we're gonna get fluids or not, right? What happens when they come into the emergency room? We push fluids right away, right at wide open. And then if we need to, we add vasopressors, right? And then we say, oh crap, look at the chest x-ray, they're in heart failure, their BNP's 32,000, stop the fluids. Let's give some inotropes, right? And then we fix that problem. But until we know, we have to do something to increase perfusion. Does that make sense? Yes.
There was a day that we had like 90 people there, or like 20, we had like patients that lined up behind our triage room. We needed a room, but we didn't have a room for them. And I specifically remember there was like a heart failure patient, and his pressure was like super low. Family member was like, well, he has heart failure, he can't have fluids. And the nurse was like, well, we can't have IV fluid or like medications running right here where there's nobody to monitor you, but like fluids will help your pressure. So that's somebody else's problem, like later on up on the floor, the ICU later to fix that problem. But for now,
Yep.
you're going to go crazy if you don't have perfusion.
Yeah, absolutely. It's so true. So I will not trick you. If I tell you it's hypovolemic shock, you think about an intervention for hypovolemic shock. If I tell you it's septic shock, you think about interventions for septic shock. If I just, and you guys know, like, I don't like to tell you what the problem is. You guys pick that up on my questions. I don't like to tell you what the problem is. I don't. I want you to think. You know why? Because nobody comes into the emergency room and is like, nurse, please help me. I'm in hypovolemic shock because I was just in a car accident and I have liver lack. Wouldn't that be easy? Wouldn't that make your job so easy? Or like, I'm in cardiogenic shock, I ate 4 cheeseburgers over the weekend. I'm having an MI. Please don't give me fluid. Please give me an iron. Super easy. Anybody can do our job, right? So I don't like to tell you what the problem is because nobody tells you what the problem is. Just the nurse, you have to figure it out. So that's why I write the questions the way I do. So I'm not trick you. If I want you to know about cardiogenic shock, I'll tell you that. Otherwise, I want you to know how to save your patient's life. Okay. Don't forget about your balloon pump, right? So remember, we talked about having to reduce afterload and why we would give a vasodilator. So you got your preload, your pump, your afterload. Well, maybe this patient is barely meeting their cardiac output. So let's say I get the pump going, my cardiac output's like, or let's just go with MAP, or my MAP is like 65. So we're like, man, we really would like to reduce afterload, but I can't give a vasodilator because I'm gonna drop that pressure too much. We can use balloon pump, right? Remember how the intra-aortic balloon pumps decrease afterload? We can use a balloon pump. So sometimes we go there. How do you know your patient's better? What was the problem? Do they still have chest pain? Hope not. They might be better if they don't have chest pain. What's the cardiac output? Better. Cardiac index? Better. Blood pressure? Better. Are they peeing? Let's hope so. Because that means we're perfusing our organ. Are they alert and oriented times 3? Good. We're fixing the problem. How do we know that they're better? Blah, 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 blah. Okay. This down here, the patients who require mechanical device therapy, like a balloon pump, LVAD, if you guys remember this from Mrs. An ECMO, you have to always be thinking about infection and bleeding. And then don't forget, if we're using these interventions, so we have to remove infection line. Remember Mrs. Phillips is like, it's a big catheter, you know, like we have these big catheters going into the patients when we think about like an intra-aortic balloon pump. Bleeding, because we have to heparinize these patients, and we have large catheters because we don't want to start a clotting cascade. So we're at risk for bleeding. You're at risk for like hemolysis and thrombocytopenia, because remember what happens in the aorta if you have like an assisted cardiac device or a balloon pump, When you inflate that pump, what does it do? It pushes some of the cells, it like smashes some of the cells against the vessel wall. So it can cause cellular damage. So sometimes you can worry about thrombocytopenia. Okay. Where's your concept map? Okay. Anaphylactic shock. This is an easy one. This is easy. Bailey, why were we checking temperatures on that patient every 15 minutes? That was getting blood. We were worried about anaphylactic shock. So we were giving blood on her patient, and the patient's temperature was like, well, what did we start out? Okay. 95. So we start blood 15 minutes later, the temperature goes up to 97. And the nurse and I are like, ah! A 2-degree jump in the temperature. I was like, let's check that again, right? So I was like, Bailey, every 15 minutes, you got to do temperatures on this patient. And they ended up being okay. But I was worried about anaphylactic shock. If you give an IV medication or a blood product that causes anaphylaxis, a lot of times the patients will complain of back pain, because as the kidneys are metabolizing that medication and filtering it, it will cause discomfort. Well, guess what? This patient was intubated and sedated. They weren't telling us about no back pain. So what happened? The guy's blood pressure dropped a little bit. He became a little bit tachycardic, and I'm like, oh my God. And of course, we were kind of like taking care of this patient. There were 2 patients crashing at the same time. And they're like, oh, you're in there with the student? Good. So people like kind of just left us a little bit, and they would pop back in, leave us, pop back in. I'm like, so poor Bailey had to deal with me for almost 2 hours straight. I'm like, are you sick of me yet? But we took care of this patient because the patient next door was crashing, but that's what we were worried about. We were worried about anaphylactic shock. What happens is it a pull, pump, pipes? It's a pipe problem. So when the blood pressure dropped, I was like, not good, right? Pumps go wide open. What else are you thinking about with anaphylactic shock? Airway, absolutely. Airway, we have swelling, we talk about angioedema. Okay. It creates this immunological inflammatory response. Okay. Most of the time, especially if you're giving IV medication or an IV blood product, you're going to see anaphylaxis pretty quickly. Okay. Nicole, do you remember that doctor that we took care of in the summer when you were in my clinical group? Yeah. And I was telling you guys the story. Who were you paired with that day? Were you? Yeah, you and Brady were together. Okay. So I went to this conference, and this ER doctor who worked for Mercy Health, and I didn't realize that was him, because I was like, are you okay with us taking care of you? He's like, yeah. So he went to this conference, and he literally, I don't know if he got exposed to he had a peanut allergy or something like that. And he said he activated his first responders, because he said by the time the ambulance would have got to where he was and actually got him to the hospital, he didn't have his EpiPen on him, he would have died. So he literally ran to the hospital. He's like, if I'm running, I'm moving. And he walked in there and he was like, I'm in anaphylactic shock. He was like, down. And they're like poking him with Epi, so he tells this huge dramatic story. And we ended up taking care of him in the summer. I was like, are you the doctor that told us? And he's like, oh yeah, that was totally me. I'm like, okay. But that is how quickly it can happen. I mean, he activated his own first responders, and he's like, if I don't run to the hospital, I'm not going to make it. There's no way that somebody's going to be able to get here in time to get me epinephrine. And he was like, could feel his airway closing off. So what do you think is the number one drug? Epi. Why? Somebody blow my mind, because then we can all go home. It activates all, every single one of them. It's the perfect drug for anaphylactic shock. Alpha. We're distributive shock, right? Wide open. Wide open. We got to clamp it down. Beta 1. I need to perfuse my organs. So I need my heart rate to be fast. Beta 2. What's it do? Respiration. Bronchodilate. And I have an airway problem here. So I don't care about the pruritus. I don't care about the itching. All that will go away. You got to think Epi. If you don't, your patient will die. This is a first-line intervention every single time in any patient that we're concerned about anaphylaxis. Okay. So if we talk about anaphylactic shock, okay, this is a pipe problem. So cardiac output, high or low? Index, Matt, stroke volume, blood pressure, SVR, low, because our pipes go wide open, right? So we lose, that's why we need the epi to clamp them down, right? So the pipes go, what about your preload? What about your CVP? Low. Everything's wide open. So your preload dilates and your afterload dilates. So decreased cardiac output, index, CVP, wedge, and SCR. Everything's low. The only thing that goes up is your heart rate and your respiratory rate. Only thing that goes up. Heart rate and respiratory rate.
So, Jill.
Yeah.
Beta 1 increases your heart rate and beta 2 bronchodilate.
Correct. And helps with the respiratory effort.
So it can bronchodilate and like increase respiratory rate.
Mm-hmm. But the primary reason we give beta 2 agonist is to bronchodilate. So after I give epinephrine, could I give my patient some fluids? Sure, my vessels are wide open. Do I want to I want to give fluids because whatever that toxin is that's in my vascular system, I want to get rid of it, right? So I got to give fluids, fill those pipes back up. I give my epinephrine. Okay, now they have a rash and they're itching. Okay, we'll give some Benadryl or some steroids or, we're thinking airway, right? So I give my epinephrine, and if my patient's still like this, are you thinking we better intubate them? Yeah, right? I'm thinking airway, I'm thinking oxygen. I can take a tube out super easy, right? We can take it out easy. Let's just get it in before it closes off, right? Okay. So hypovolemia due to relative loss, right? This person's not blood loss. They have a volume loss because the pipes are wide open, right? Pipes are wide open. Low cardiac output due to afterload, preload, abnormal breathing pattern, bad gas exchange. Okay, what's our problem? What's our cause? Okay, so good. We've got to stop the offending agent, right? So I've seen people go in and treat somebody for anaphylactic shock and the antibiotic's still running. Like, stop the antimicrobial. You can give epi all day, but if that shit's still running, they're going to stay in anaphylactic shock because they're having a reaction to it. So I'm talking disconnect it. Even if we're going to run fluid in, you don't even run fluid in the same tubing. Like disconnect it from the IV. Brand new tubing, brand new bag of fluid, running it in the IV, running it in the site. You don't have to get a new IV site. It would be hard to anyways, right? Because you've got all this vasodilatation going on. It would be hard to get a new IV site, but stop the agent, okay? Support the airway, epinephrine, steroids, Benadryl. I'm sorry, I was like ahead of myself. Anything on here you want me to go over? If we give epi, if we give fluid, if we stop the offending agent, we intubate the patient, give them oxygen, give steroids, give Benadryl, and my cardiac output's still bad, I can have an inotrope. I don't need to give more fluids, I'm already giving them. I don't need to add a vasoconstrictor because why? We're already given one. Epinephrine's a vasoconstrictor. So I don't need to add another one. I'm already given a vasoconstrictor. I just got to add something else so I can add an inotropic agent. I rarely see that we have to do this, but it's in the literature. So there you go. Okay. Ventilation, volume replacement, emotional support. These people feel like they're dying. Anybody ever have an anaphylactic reaction? Did you feel like you were dying? Yeah. Do you mind me asking what your allergy was, or?
I saw it.
Oh.
I have no idea. I went to like the drive-in movie, so I think it was something like plant. And but it didn't it happened overnight. Right?
Uh-huh.
So it was very weird situation. But then I woke up and I said my foot feels like a straw. Drove myself to the urgent care, and then they said they were calling an ambulance, and there was I had Strider and They almost intubated me and I had to stay overnight in the ICU and like,
Yeah.
I don't know if it was technically anaphylaxis.
Did they give you epi?
Yeah.
Yeah. How did that
I
feel?
don't know. I was like, I don't know what's
Yeah.
going on.
Yeah, it is because it makes you so tachycardic and it activates all of your first responders. So patients are like, you know, so that's why, like, now listen, this is on here, like emotional support. Okay. Did anybody ever write that as your priority nursing diagnosis in the ICU? Everybody please say no. Okay, good. Nobody did that, right? Not unless you called in hospice, right? So I use this example. If your patient's airway is closing off, you're not going to go up and hold their hand. I'm so sorry this is happening to you right now. We do the best we can. However, and I say that jokingly because, you know, sometimes when the students, and I didn't really see this with you, but you guys did really good with your care plans, but I sometimes will see students will be like, this is a lot. We better provide emotional support. I'm like, well, if their cardiac output's in the crapper, holding their hand is not going to save their life, right? So don't forget you have to fix physiological problems before psychological problems, right? So I say that because these patients that get epinephrine and feel like they're going to die are very, very stressed and very, very traumatic for them and the family. However, give the epi first. Make sure we give the oxygen first, right?
I was very distraught. I accidentally told the people when I got to like when they transferred me or whatever that I got an epidural. They were like, you mean epinephrine? I was like, I don't know.
It was terrible. They gave me an epidural. I couldn't breathe.
They started laughing at me. I was so mad. I was so upset. I was like, what do you want to do? I had no idea. It was like,
Oh my gosh. Of course. I mean, it would be terrible. Yeah. Yeah. So we'll do sepsis and mods and DIC when we get back. Okay. Do you guys want me to stop this recording and start a new one? So it's like not too, okay. Sure.